Hi folks, this is Dr. Rob CYWES. I am the carb addiction doc, and I am going to say something and then explain it. I think that Dr. Peter Attia is absolutely brilliant, very, very smart in his knowledge of biochemistry and physiology. However, I also think that Dr. Peter Attia is completely misguided and incorrect and wrong about the advice and the approach he takes to healthcare. And I would love to be able to make a correction of a video I just watched very intensely, which is a brilliant video, and I think everybody should watch this. Peter Attia sat down a while ago, and the link will be in my show notes, with a Dr. Ralph DeFranco, who's a self-proclaimed expert in diabetes management. And while I agree that Dr. DeFranco has done a huge amount of research and science that I've learned from and I've benefited from, and I give him full credit for that, it is so incredible when I watch these two brilliant, smart physicians talk that they completely miss or do not speak of two major fundamental issues that define type 2 diabetes. And once you ignore the foundation, you cannot build a house of care. So let me break it down and let me talk a little bit about the appropriate management of type 2 diabetes. And I'm going to use some of what they spoke about correctly, but it's based on a differential foundation. In fact, it was interesting that Ralph DeFranco actually mentioned he slid in to the video that he only eats once a day. Intermittent fasting. Never spoke about it, but slid it in there that, oh yeah, but I only eat once a day. Just slid that in there. You would have missed it if you weren't listening carefully. Having said that, ultimately, type 2 diabetes is very simplistically a defense. It's not a disease. It's not a disease. It is the culmination of a protracted defense mechanism of the human body against a perpetual tsunami of sugar and starch by you, the human being, and a genetic basis of a low insulin production capacity. You can produce a decent amount of insulin, more than you need, but not enough to clear sugar from the bloodstream. And the body's defense, the cellular body's defense against that, elevated insulin, elevated blood sugar, is to block the entry of sugar into cells. Now, the body tries to defend that in type 2 diabetes. So in the liver, at first, the liver is going to work really hard to turn excess sugar into fat. And we know that by measuring triglycerides. Those triglycerides then get shipped out in VLDL to the fat cells where they get deposited. And the fat cells, despite my friend Ben Bickman's statement, the fat cells are an inert energy storage, glucose fat storage repository that is relatively inert in terms of damage it does to the human body when it is the adipocytes that are peripheral, that are subcutaneous. Adipocytes elsewhere that are being secondarily recruited as another source in the organs, in the muscles. That is pathology. That is the body throwing up the Hail Mary of deposition of this tsunami of energy. So diabetes, type 2 diabetes, is a culmination of a defense mechanism based on a genetic inability to produce unlimited amounts of insulin. If you can produce unlimited amounts of insulin, you don't get type 2 diabetes, period. End of story. Other diseases happen. Okay, so in people who have a limited insulin production capacity that is relatively high, if you can't produce insulin, that's type 1 diabetes. But type 2 diabetes is not related to a primary disease of the beta cells, of the cells that produce insulin. They're normal, they're happy, they're functioning well, but they have been homeostatically damaged by this perpetual onslaught of activation. And even the beta cells have worn out but are recoverable. Hi folks, this is Dr. Rob Cywes. I am the Carb Addiction Doc, and to celebrate my 100+ pound weight loss, I have run something called the Gate River Run every year. They give you a big ass medal, and it's kind of like my chip equivalent to alcoholics that's been sober. But one of the things I've used for the last couple of years is Ketone IQ. And Ketone IQ, I used last year. It was a terrible race. It was very muggy, very warm. So I didn't have the fastest of times. I typically run about a 10-minute mile over 9.3 miles. Very slow, but I'm proud of it. This is Ketone IQ, the regular formula. I ran on this last year, and it certainly gave me those 2 energy bumps so that I was able to run the race relatively easily despite awful conditions. But I still was dragging a little bit. This year, flavoring was an issue. This new Ketone IQ product is flavored with green tea, much more palatable on the run. And also, it has a little secret weapon. It's got some caffeine in it, 100 milligrams of caffeine, the equivalent of a shot of coffee, which I used before. By the way, I run fasted, 36-hour fasted. So I'm running on ketones. This little bump, the beginning of the race and halfway through the case, tolerable by taste, with a little bit of a bump from caffeine, really helped me to manage that race well. And yeah, it's an experiment. I tried it, but it certainly works. And if you're an endurance athlete who's running for more than 45 minutes or doing endurance exercise, swimming, biking, whatever it is, for more than 45 minutes, I strongly encourage you to take either these or the little gel packs with you and hit these guys about every 45 minutes just to even out your fuel supply. It works. Try it. The other thing that we have to take into consideration is that 70+%, great quote from Ralph DeFranco, he's done the study, 70% of the insulin that gets released by the pancreas is released based on carbohydrates triggering GLP-1. Okay? But it's kind of the cry wolf thing. You know, cry wolf, where you go knock on the door and they open the door and nobody's there, and then they keep knocking on the door and nobody answers the door. You keep yelling fire when there's no fire, and then one day people ignore the fact that you're crying fire, there's usually no fire, and then suddenly there is a fire and you ignore it and you get in trouble. Well, cry wolf is what happens in the gut. So when you've got this onslaught of triggering of GLP-1 continuously by carbohydrates and by snacks, the GLP-1 signal gets dulled down, gets blocked by the beta cell, and it doesn't respond adequately. And we see this in people who are insulin resistant, and we see this in people who are high-fat carnivores over time who become insulin suppressed, where they're not eating carbohydrates, they're not triggering GLP-1. So truly, insulin resistance is a combination of cellular resistance to insulin in the body. And here's a new concept you've never heard about. Nobody's ever talked about this that I can find, and I am. Beta cell resistance to GLP-1. So what we call GLP-1 resistance. You see how our knowledge is growing? So we've got 2 components. Everybody's talking about insulin resistance, but we also have to discuss GLP-1 resistance. Beta cell resistance and the rest of the body is resistance to GLP-1. Okay? Where the gut can produce so much GLP-1 and not more. So the common thing that we're doing now, and everybody's having success about this, remember I said earlier on that if you have an unlimited capacity to produce insulin, you cannot have type 2 diabetes. Well, in exactly the same way, if you have an unlimited production of GLP-1, you're also triggering the beta cells to have an enormous production of insulin, and you don't get type 2 diabetes. Okay? What are we doing medically to overcome GLP-1 resistance? If you can only produce this amount of GLP-1, what we're doing now is we're injecting Ozempic, we're injecting tirzepatide, Mounjaro, and we are massively increasing GLP-1, which triggers more insulin, which blocks more glucagon, and it corrects insulin resistance. So by correcting GLP-1 resistance, we are also simultaneously correcting insulin resistance. And the Peter Attia, Ralph DeFranco didn't even consider that. That's why I'm comfortable saying that, to my knowledge, and I listen to a lot of folks and I read a lot, to my knowledge, this is the first time that we have connected GLP-1 resistance to insulin resistance. And it's a combination of those two. Okay? Comes from my clinical practice. So the second important thing that is crucial in the understanding of type 2 diabetes is the role of glucagon. Because glucagon is the hormone that regulates energy released from stores in the body to the rest of the body. And a large part of insulin and GLP-1's role is to regulate glucagon. And if glucagon is unregulated, if there's this insulin and glucagon should function equal and opposite to each other. But if there's this glucagon-insulin dysregulation, where you've got paradoxically elevated insulin and paradoxically elevated glucagon, so you've got resistance to insulin, you can't get the sugar into the cells, and yet glucagon is pumping more sugar and releasing more sugar from the body into the bloodstream, you've got, again, the tsunami effect. And while GLP-1 resistance not only affects insulin, it also affects glucagon, because GLP-1 should simultaneously block the alpha cells from releasing glucagon as well as promoting insulin release by the beta cells. But if you've got glucagon resistance or GLP-1 resistance or GLP-1 insensitivity, you're not getting the insulin, you're not getting control of glucagon. So you've got the worst of worlds where you've got this massive amount of sugar being released into the cells. And at a hormonal level, that control eventually leads to type 2 diabetes. Okay, so that is never discussed. Never ever discussed, because the cause of GLP-1 resistance, the cause of insulin resistance, the cause of hyperglucagonemia is simply and exclusively chronic excessive carbohydrate consumption. Chronic excessive carbohydrate consumption in a person who has a genetic limitation of either or both GLP-1 and insulin production. That's the simple foundation. So if you talk to my 4-year-old child and you said, Rian, my boy, we've got something that somebody's eating and drinking that is causing damage to them. Do you think Rian's, as a 4-year-old child's first response, and he's a smart kid because he's a carnivore, do you think his first response would be, well, give them medicine to prevent the damage? Give them all these drugs to protect the damage? Or would the obvious answer would be, stop eating the shit that's making you fat and sick? If chronic excessive carbohydrate consumption is causing all of this, why the hell does Attia and DeFranco spend 2 hours very scientifically talking about all these diseases as if they're real entities rather than just protective mechanisms by the body against what you're doing to yourself, and they medicate the shit out of all these diseases? That is upside down thinking. But if your thinking is that these are diseases caused by blah, 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 and they're dealing with it at a cellular level, and they're throwing medication after medication after medication at you. My 4-year-old son has more capability than Ralph DeFranco and Peter Attia, as brilliant as the two of them are, to just tell you, Dad, don't let them eat carbohydrates. If you don't eat carbohydrates, you can't have type 2 diabetes, period, end of story. Now, it may take time for the system to correct itself. So therefore, fundamental to the treatment of type 2 diabetes is a low carbohydrate, high fat diet. And as you'll see in a video that's going to drop soon, or has dropped, from India, where 200 million people have type 2 diabetes, just by decreasing the amount of carbohydrate from 80 to 90% of their diet to 50 to 60% of their diet, they are putting their type 2 diabetes into remission. 200 million people who previously were reliant on medications to slow down the progression of their disease. By doing what my 4-year-old son says, getting rid of carbohydrates, they're reversing their disease. Never mentioned, never once mentioned in a nearly 3-hour video called Masterclass in Insulin Resistance, never once mentioned that. slid in intermittent fasting. That, oh, I only eat 1 meal a day, says Ralph DeFranco. Never advocating that for his patients or as a management system. Bought and sold by pharma. And Ralph DeFranco, the biggest criticism of him, apart from that, is he's bought and sold by pharma companies. Paid for, bought and sold. And I understand it. I understand that the only way for him to do his research is to use the wealth and the money that is contributed by pharma, but then he's biased totally by medication. And that is my biggest criticism of Ralph. I wish that he could speak freely, free of the need to generate support for his research from these pharma companies, from the NIH, and toe their narrative. But never once mentioned sugar, never once mentioned low carbohydrate, never once mentioned GLP-1 resistance or glucagon. Now, let's move on from there. So how do we treat this? Number one, then, the foundation is a low carbohydrate, healthy fat, healthy protein diet. And even if it's a 60-20-20 or a pure carnivore diet, they all work in different degrees. So that has to be the foundation. Now, medication-wise, and this is where DeFranco and Attia certainly educated me and corroborated that what I was already doing in my practice is useful. And again, this is where pharma comes in, because pharma does not talk about these two as, I love this from Attia, he says, these medications are essentially free. And they are, they're dirt cheap, cheaper than a cup of coffee at Starbucks. So while you are getting rid of your type 2 diabetes by changing your diet, there are 3 synergistic medications that I believe are crucial for you to use. Number 1, and most people are going to find a reason to reject this because they haven't become tolerant to it, is a biguanide called metformin. Metformin costs nothing. And it is still a great drug. What metformin does, and what it also doesn't do, well spoken by Ralph DeFranco, what metformin does is it blocks glucagon's release of sugar from the liver. So it blocks the glucagon you release, the addition of sugar from your liver in the face of already high blood sugar, which allows your body to mop up the tsunami of sugar you're eating. So metformin, and you start out with a very slow amount. Yes, metformin does cause GI upset. And most people abandon it within a week or 2. They're either overdosed or they didn't allow themselves to get used to it. So you start with, first of all, an extended release metformin, and you start out with 500 milligrams once a day, and you slowly go up to 500 twice a day or to 1,000 twice a day, which is, if tolerated, my recommended dose. What metformin does not do, and Ralph did a great job of speaking about this, and I agree with this, it does not create insulin sensitivity. That's a fallacy. I can see how people assume that, but it's a fallacy. The primary role of, and think with me, the primary role of metformin is to block glucagon. So you don't have this addition of sugar to the bloodstream. Second drug is a very, very old, simple, dirt cheap, as Peter says, free drug called Actos. Actos is pioglitazone. Actos is a drug that regulates fat and glucose metabolism in muscle cells, fat cells, and the liver. So there's something called a PPAR gamma, peroxidase proliferator receptor gamma. Big name, you can Google that. The name of these biochemical things always gets stuck in my throat. But what Actos or pioglitazone does is it sensitizes muscle to insulin. So remember, the muscles block insulin, and it works at the mTOR level, which is another molecule within the cell that regulates the opening of the glucose channel, and it's affected by insulin attaching to the insulin receptor. There's science behind that. They go into a little bit of the science in the Attia Talk. You can chat GPT that. But essentially what happens is when insulin blocks to a receptor on a cell, that receptor is blocked, it's phosphorylated. And what Actos does is it is an antagonist for the receptor that causes that blocking. So it sensitizes muscle to the uptake of sugar, so that insulin gets the sugar to go into the muscles where it either gets stored and used as fuel. And yes, it's important in skeletal muscle. That's why physical activity is important. However, Actos is also crucially functional. In the muscle, most people don't even think of as a muscle. but it's one most people are worried about, which is the heart. Cardiac muscle, skeletal muscle functions the same. So you increase sensitivity to the uptake of sugar by muscles and insulin sensitivity, which improves the insulin resistance that causes heart disease and muscle dysfunction. And then finally, it sensitizes adipocytes, fat cells, to take up sugar, and within the fat cell, under the guidance of insulin, you can get DNL, de novo lipogenesis, the conversion of sugar to fat. And it's the same process that lactose sensitizes the liver to also convert sugar to fat. So your triglycerides may go up with lactose, and you may gain a little bit of weight with lactose. The weight is a little bit of fat, but also some water weight. And Ralph DeFranco goes through a good detailed discussion of why this happens in the body. But again, they forget to think about what you can do about it, because their assumption is you're still eating carbohydrates. So if you're going to go on lactose, the easiest way to avoid the primary side effects of lactose, which are fluid accumulation, weight accumulation, and then putting stress and strain on some of the organs like the heart, that has to pump that blood. So it's blood pressure, it is heart failure, is to do two things: to replace sugar with fat and protein. Lactose for me is one of the commonly used drugs, and I'm much rather, if somebody comes in on something like an SGLT2 inhibitor, which I completely disagree. Attia and Ralph DeFranco were very gung-ho on the SGLT2s. I absolutely disagree with that. I can go into that for a different reason, but I stop those when I first see a patient. They damage the kidney, they cause ketoacidosis, terrible drugs, don't have the benefits on a ketogenic diet they should. However, heavily promoted by the drug affinity that DeFranco and Attia have. Big criticism right there. However, I stop the glyburides and the glipizides, and I replace that with lactose. I stop the SGLT2, so the sulfonylureas, which drop blood sugar too much, as well as the SGLT2. What's that? That's Farxiga, that kind of medication. We stop those, and I rather replace that with lactose. And I think that the metformin lactose combination is a brilliant combination of blocking glucagon, so you don't get the release of sugar, and then enhancing the sensitivity of the liver, fat cells, and muscles to take up more sugar. So you're clearing the bloodstream, and you're also storing or using that sugar. And that's where exercise comes in. And then the third medication as the triumvirate, as the three musketeers that are most effective in diabetes management, are the GLP-1 agonists. The GLP-1 or incretin type drugs, whether that's a pure GLP-1 or whether it's a GLP-1 plus a GIP, which delays the breakdown. There's one drug I completely disagree with, and we'll talk about that in a second. However, whether it's Mounjaro, which is a GLP-1 GIP, whether it's Ozempic, which is a pure GIP, semaglutide, liraglutide, or tirzepatide, those are the third drugs. And what they do is they correct GLP-1 resistance. They are GLP-1 drugs. So when your body has produced this much and you're resistant to that, they increase the amount of GLP-1 that improves the function of the pancreas by increasing insulin release, and also by creating insulin sensitivity in all the organs that are affected by insulin. And they also, together with metformin, block glucagon. So they affect the alpha cells, the beta cells, as well as the insulin uptake or the insulin receptor at all cells. So my combination is a GLP-1 agonist, with or without a GIP antagonist or agonist, lactose, insulin sensitization, and metformin, glucagon blocker. The drug that I do not think should be used in type 2 diabetes, and it's misguided thinking. Here's the misguided thinking. Eli Lilly hasn't produced this drug yet, but it's called retatrutide. It's a triple G. It's a GLP-1 agonist, a GIP agonist, and a glucagon receptor agonist. Now, the glucagon receptor agonist is done because on the GLP-1s, when people are eating a lot of carbohydrates, we see they drop their blood sugar too low. So now what they're doing is they're saying, okay, let's enhance glucagon. Let's make glucagon work more, so glucagon is releasing sugar while the GLP-1s are increasing insulin, which is a terrible way of thinking, a terrible formula. Yes, you lose weight, but it's a terrible formula for type 2 diabetes. One of the reasons it hasn't been released yet is because of the ambiguity of that use. Quite frankly, what you need is a glucagon receptor antagonist, not a glucagon receptor agonist, to block glucagon, and then that retatrutide GLP-1 GIP with a glucagon receptor antagonist would be the best darn drug as a single entity, as a single combination for the management of diabetes. Because it has then the actose function and the metformin function rolled in. But Pharma Eli Lilly doesn't think that way. They're worried about hypoglycemia, which is ridiculous because nobody talks about stopping eating carbohydrates. If you get rid of the carbohydrates or even reduce your carbohydrate consumption, you don't need to be releasing more carbohydrates to counteract the blood sugar dropping effect of these drugs. Because if you're releasing ketones under the influence of low-dose glucagon and you've got a relatively even-keeled blood sugar where you're not seeing these hyper cycles, then you don't need glucagon to protect you from low blood sugar. So in summary, folks, here I think is the best way to treat type 2 diabetes to remission. Number one, a low carbohydrate diet, where that increases high fat, leans a little bit more to animal products, anywhere from a 60-20-20 to pure carnivore, but an ultra low or a low carbohydrate diet to the extent you are possible. That's the foundation. Then getting a CGM to monitor your blood sugars. And what you want is you want those spikes and those lows to level off, to become flatline, and to drop below 95 ideally, or below 100. So we want a flattening of your blood sugar profile at a low blood sugar level, not low, but a normal blood sugar below 95, somewhere between 65 and 95, but monitor with a CGM. Okay, those are the first two fundamental things. The third fundamental I would do is be physically active to the extent you can to triage sugar to the skeletal muscles, which are the largest repository for glucose, for glycogen. So physical activity to the extent you can, and make that a routine. Then we add in metformin, starting at a low dose, get tolerated to your stomach. It's going to be rough for the first week, and then slowly build that dose up. Secondly, add Actose in exactly the same way, starting with a low dose, 15 milligrams, going up to 30, never really getting to 45 except in exceptional cases. And then thirdly, if warranted, adding a GLP-1 combination drug or a GLP-1 agonist. Those are the three drugs I would do. Also, as a priority, every type 2 diabetic should be screened. When I first come into my office, I routinely do this, get a CAC score, and if the CAC score is above 80, that needs a workup, but also start them on a baby aspirin if they can tolerate it. That is my management. That is type 2 diabetes, folks. We do that in my office. If you want to consult with me, 561-517-0642. Set up a consult. We'll help you to manage. We'll do the blood work, and we will track you to remission and help you to stay there. Because once you're on those medications, we can then wean you off. We can wean you off as your pancreas recovers. Because remember, your pancreas is normal. It's just gone into defender mode. It's gone into defender mode. Think of the pancreas like an old castle being sieged by sugar, and it goes into defense mode. And if the siege lasts for a long time, the pancreas suffers, but it is recoverable. It will rebound. Type 2 diabetes, by definition, is treatable to remission. And of course, as part of that, we need to make sure that you don't have antibodies to insulin, which is LADA, which is actually a type 1 form. So we'll always do that testing in my office. And the final comment I'll make is occasionally, just like we use GLP-1 to increase GLP-1 resistance, we may also, and I have an early threshold for this for a little while, to gain control of your blood sugars, to actually use insulin directly to overcome the ceiling of insulin. So the problem with type 2 diabetes is a low ceiling for GLP-1 and a low ceiling for insulin. The GLP-1 agonists raise this ceiling, and occasionally we may need insulin to raise this ceiling. Boom shakalaka, there's my management protocol. Please leave comments, and if you're a type 2 diabetic and you want help, reach out to us, set up a visit. But that is where the brilliance of DeFranco and Peter Attia is less than the pragmatic obviousness that a 4-year-old child can treat type 2 diabetes better than a 2-hour masterclass in insulin resistance by DeFranco and Attia. I will put my son Rian, a smart 4-year-old, up against those two, and he will help more diabetics correct their disease than both of these brilliant doctors have done over their entire careers. Woo! I am the Carb Addiction Doc.